So now we get started. So I'll share my screen. I don't know, is this the case, Davide, you will be, you maybe comment on, but I can walk through the PDF and then you can maybe add to, from your personal experience, how much that.
As you prefer.
Yeah.
Just a disclosure before we start. I'm a radiologist, not a cardiologist, so my interpretation of ECG, for example, will be absolutely.
Oh, no, nobody, nobody expects that. So,
yeah,
but
okay.
just in order to open the context, so of course, these are the times where we all are involved. All of us are involved in the epidemic and the pandemic of the coronavirus disease called COVID-19. And we have now more than 1.2 million cases, and we have probably now about 80,000 deaths. So it is a very contagious disease. Each infected person will infect about 2 others. And it spreads very rapidly and thereby just overloads the healthcare systems. And initially started in China, but then the countries most probably hit very recently. But could I ask everybody to mute yourself if you're not speaking, because otherwise we, thank you. So the countries currently most hit are Italy, where we hope that they have already passed the peak. But Spain has actually, I think today has passed Italy in terms of the number of cases and deaths. And France is the next one, and then it's probably going to be Germany, where we already see here. I'm actually calling from close to Berlin, and then UK, Sweden, with a fairly lenient approach. We see a huge surge of deaths now, so probably that's at least in part caused by the relatively open policies around social distancing or physical distancing, which is the better term. And then most strongest hit in terms of the absolute numbers definitely is the USA, which will probably soon have more cases than all the rest of the world taken together. And again, there was a fairly late response with social distancing measures, and there are also other factors in the healthcare system that will make it very problematic. We thought that with this journal club, we want to offer a source for rather effective information. So we start, and we always are most focused on imaging, to some extent to cardiac MR imaging, because that's where basically many of us come from. So I will also comment briefly on that. So before we go into that case report, actually acute disease with severe acute respiratory syndrome has been reported before to cause plaque instability. And this is one of the early case reports. So that is one of the outcomes. And then there are other reports actually from this pandemic of fulminant myocarditis, so direct inflammatory involvement of the myocardium in the viral disease and the immune response, which is very important to discriminate because the virus itself triggers an immune response that in the lungs is especially deleterious because it leads to the accumulation of a kind of a gel-like substance and a widespread severe injury. Then there have been also reports on cardiac involvement, and this one was one of the first, and actually the first looking also at cardiac MR. So this is the case of a 53-year-old woman who presented with severe fatigue, had fever and cough the week before, had a relatively low blood pressure, high heart rate, and slightly increased pH. The ECG showed low voltage in the limb leads that typically is associated with pericardial effusion. And the chest X-ray was unremarkable, but maybe Davide, you can comment on that. What you thought of the chest X-ray? What do you think it helps? And also maybe with a little comment on how chest X-ray in general help in this disease.
Yeah, okay. So in this particular case, as you said, chest X-ray was totally unremarkable. Generally speaking, chest X-ray has probably low sensitivity, definitely lower than CT, but it's fast and it's a convenient way to, at least as a first screening tool in these patients. The policy we adopted towards CT is to perform CT when there is discrepancy between clinical findings, oxygen saturation, and a normal chest X-ray. In those cases, frequently we observe changes in the CT scan that are not possible to see on the chest X-ray. But chest X-ray is very useful, and the Italian Society of Radiology has actually advised the use of chest X-ray.
Okay. Thank you. So then the patient also expressed signs of myocardial injury, an increased troponin level, an increased BNP, so a marker for heart failure or increased pressure in the atria. And here are the blood values over time, but in the interest of time, let's move on to the more imaging focused findings. So there was an echocardiogram performed that showed an increased wall thickness and a diffuse bright appearance of the myocardium, which is an interesting observation that has been associated by some previous case reports in other diseases with inflammation or with more widespread diffuse tissue abnormalities, although it is not really specific for any of these. The ejection fraction in this patient was decreased, and there was a pericardial effusion, a circumferential pericardial effusion. Now then, the doctors around Davide also performed a cardiac MR scan, and what you could see there is, and maybe Davide, I'll let you just comment on that.
Okay, so there was diffuse hypokinesia of the left ventricle, and the ejection fraction was somehow lower than what had been observed on echo. And then we were amazed by the thickening of the left V walls, and this had already been seen on echo. We saw a maximum thickness of around 14-15 millimeters in the anteroseptal vein. And there was signal changes on the STEER image, which is on top, but this many times is not totally reliable. So we performed the T2 maps, which show these widespread and patchy changes in the T2 relaxation time. I think that the peak we observed was around 73 in the apical part of the septum on the 4-chamber view. And when we injected contrast, we saw a diffuse enhancement of the entire LV, but enhancement was also present in the RV and in the atrial walls. Yes, in these images, you see that it's so diffuse that to some extent it may resemble what happens in amyloid. And it is absolutely something we had never seen before in a myocarditis. It's not what you find in books for myocarditis, at least as typical.
Actually, that was my question, because these images almost look like you either didn't pick the right inversion time, or what I think you definitely did, or it's really so diffuse that it really resembles almost amyloid disease with a very diffuse, widespread involvement of the extracellular space.
Yes, if I may, based on images, I agree with you that this is a possible differential diagnosis. But of course, everything has to go into context. Yeah. If you may switch back to the table with all the details of lab tests, I don't want to bore you, but I think it's interesting to see that many of the parameters like troponin, CK, and T-brom-P tend to peak around day 3, day 4, they increase steeply and then peak around day 3 and 4, and then they um, more or less rapidly they tend to decrease. So it looks like there is something very acute going on with this lady.
Yeah.
And actually, she came with 40% ejection fraction and got home with 62% ejection fraction in more or less 10 days of hospital day. So it's really...
Yeah, that's a strong argument against amyloid disease or any other chronic, more long-term. There's a question from Mohammad that I will forward to you, Davide. So he asked, does the X-ray show a loss of a cardiac waste?
I think yeah, I've seen the question. I think probably he's talking about the shape of the right contour of the heart. But this might also be probably due to incorrect positioning of the patient. This was acquired in the ED with the patient standing, not a PA, it was an AP, anterior posterior projection. So this may be the reason.
Yeah, one more question coming, and I'll just reword that a little bit. Was it surprising to you, or we don't have the CT findings here, not the images, but would you expect in such a case also pretty significant CT involvement, or could this be a pre-existing cardiomyopathy and the patient having a COVID on top of it? So that is just the question as it was.
Yeah, it's a very good question, but unfortunately I cannot give you an answer. What I can tell you is that the remote history of this young lady is completely normal. So it's difficult to, of course, it could have been clinically silent cardiomyopathy going on, but there were no signs indicating again amyloid. And the other point, which is interesting, I think it is in the, no, it is in the case report, is the fact that the thickening of the LV walls decreased over the, and when the patient was discharged, the thickness was more or less normal, around 11 millimeters for the septum. So again, this is an argument for something that has gone very fast and very violently.
Yeah, and I can also confirm that I have seen severe myocarditis cases where you also had edema, quite significant edema, just looking at the wall thickness that then receded. So that is also certainly a very good argument that we're dealing with myocarditis here. So I don't know, last question to you, Davide, before we move on to the next paper. First of all, thank you very much. This is, I think, very valuable and very important insights here. So the question I have then is, do you have any other experience with cardiac involvement that you may have seen, and can you comment on what you discussed here, or what you put in the discussion? Is this an early or a late phenomenon? Do we have to expect that myocarditis happens early, which means during the first phase of the viral, the overwhelming presence of viruses, or is it a second one, which is more an autoimmune or immune response, or a consequence of a cytokine storm, for example? So,
as you may imagine, I can only give you some hypotheses.
Yeah,
and there is no evidence about the heart. The evidence about the lungs is that normally pneumonia tends to develop around day 7 after the onset of symptoms. So we are probably talking about something in the mid to late phase, and probably something much more related to the exaggerated inflammatory response to the host rather than to the virus itself. And possibly also what we've seen in the heart in this lady might be some sort of the same that we see in the lungs of people affected by pneumonia. So a diffuse inflammation of the myocardium generated by the response of the immune system. And actually this patient did very well with methylprednisone. So this might more or less indirectly confirm what I'm saying.
Yeah, that's what I also, if I may say, so I also would submit here. It is more likely that any myocardial involvement will be part of the immune response and not so much of the primary invasion. And similar to the ARDS, where basically the inflammatory response then kills more than the virus itself. Yeah.
Yeah.
Thank you so much, Davide. And
thank you very much.
Feel free to stay on. And also thank you very much for the work you're doing for your people there. And
Thank you very much.
So the next one we wanted to discuss, and I'm sorry for this annoying green. I hope this is, I don't know how to remove that here, but I hope it will not interfere too much. The next paper I wanted to present is, or we will not go through that in very much detail. In fact, what I wanted to show a few papers that I found informative. They are all posted on the website. You can all download them as PDFs. So I'll just briefly say what each paper has to offer. And I don't know, I spoke with, or I had an email exchange with Dr. Parikh, and he is not able to join because he's actually, as we speak, on the COVID unit. But is someone else from that group joining and would jump in here? If not, if yes, then speak up. If no, I'll just quickly go through the paper. I think it is published in JACC, and it's called Cardiovascular Considerations for Patients, Healthcare Workers, and Health Systems During the COVID-19 Pandemic, and has several names that are known, like Harlan Krumholz, Greg Stone, and so a lot of people have worked on that. So it certainly provides some expert knowledge. In brief, the highlights from my point of view are as follows. So the starting point for them was that what we know, pre-existing cardiovascular disease predisposes to complications associated with COVID infection, and even may themselves. And COVID infection is not the right term because COVID is the disease, that it's coronavirus. So I'm not sure they are more prone to the virus infection itself, but certainly they're more prone to developing clinically more severe COVID-19, so the disease itself. If the outcome of these people is impaired, if they have pre-existing disease, then there are indirect effects. So because there may be people with a regular MI and they cannot access the hospital because the hospital is just overwhelmed with COVID patients. And this is a very interesting discussion, and I will not have the time to go into that, but we have seen in several countries, and I know, Davide, from Brescia was the same reports, there's an almost like magic reduction of cases with acute coronary syndrome and infarcts. And that has been observed in China, in Italy, in Germany, in the States, in Canada, whoever I speak with, they all say, yeah, where are all these acute coronary syndromes? And in fact, the question is really interesting, and there's not one single explanation for that. It may be a combination of several things. One, people may stay at home, although they should go to the hospital because they're really sick, so they may die at home. Then another one is that, yeah, they were basically meant to have an infarct, but now they got COVID, and then the COVID did the blow to them. So it's not entirely clear, but it's a phenomenon we have observed. So for example, in Montreal, where we have been preparing now for weeks, the cath lab is actually not busy at all. They have 1 to 3 cases a day. That's unheard of. Whereas, of course, there are there's an increase of COVID patients, but not as much. So this is an interesting other discussion. And then we know that if we treat disease with pharmaceutical agents, all of them have side effects, and some of them can be actually pretty significant for the cardiovascular system. So what they then do, they first talk about, let's say, the general information and the case fatalities, and then they list potential reasons for the difference in cardiovascular outcomes. And this is like a good summary of the existing evidence so far. And maybe the most important is that the case fatality rates really depend on the pre-existing disease. So in a nutshell, whoever has cardiovascular disease or diabetes or hypertension has a worse outcome. Whoever has a troponin has a worse outcome. So there's a link between that. So the inflammation itself, of course, is a stress to the cardiovascular system. So plaques make it unstable. Then there is a strain to the cardiac output that is required. And if that cannot be delivered because of pre-existing heart disease, then the whole system tips over and patients go into cardiogenic shock or cardiac shock and then multi-organ failure. Then they discuss potential mechanisms of increased risk, and they point out what we already discussed. Very important is the immune system. So those with a dysfunctional immune system will have more symptoms because their immune system is too weak to keep the virus at bay. And then, ironically, those young people with a very responsive immune system, they may be the other group that may be at risk. I mean, the whole issue with COVID, one is the contagious nature of this agent, which leads to fast spreading. And the other one is that the immune response, as already was observed in the SARS pandemic, can be overwhelming in young people, so that although the overall mortality in young people is relatively small, 0.1%, but if you infect 1 million people, then you have 1,000 people who then die. So you have in absolute numbers, you're scary. And it's especially scary that in Italy, 50 or 60 of our colleagues have died basically in the front line. From New York, colleagues of from New York have reported that young residents die. So the exposure on these wards to a large amount of virus can then in these young people lead to these massive responses. And it's probably a matter of the virus load, because to me, it looks like a lot of people working on these wards where there's aerosolization. That is probably a bigger problem for younger people than just occasionally on the jogging path, running into someone. And the other problem has been these large gatherings of young people that happen in Italy. I know that there were, just as in Germany, it's nothing special about Italy, but they had these Corona parties where the young people thought, hey, great, we have a good time here. We don't need to go to university. And we had all over Europe and in the States, we had gatherings because just for people, it was not clear what was the consequence of that. So the immune response is a very important one, too weak in the old and too strong in some of the young. And then they discuss the potential outcomes of cardiovascular complications. So that is myocardial injury, myocarditis, and acute coronary syndrome. So it looks like, from what we know, that it's more a problem of too much strain on the cardiovascular system in general, not necessarily that the virus itself has a specific. On the other hand, the ACE2 receptor, which is basically the door opener for the virus to cells, is especially present in the lungs and the heart and the intestinal system and the kidneys and in the testicle system. So there are regions where the ACE2 receptor is more prevalent, and that may be a reason why an inflammatory response can be particularly severe there. So looking at the literature that was commented on so far, and that's what they also report, myocarditis was not that frequent. So so 7% is a number they cite from one of these studies that probably reflects the experience so far. So it's not very frequent. I know from China, they find it even less frequent. I don't know what, Davide, if you would have to give a number, what's your feeling? How often could it be myocarditis and not just the shock or underlying coronary artery disease?
It's again very difficult to say, because we are collecting huge numbers about these patients, and we see that in a lot of patients you have troponin rise, And it's very difficult to understand. And this is probably one of the next steps to understand whether this troponin rise is directly related to myocardial injury or not. So it could be that we are underestimating, or but clinically speaking, we don't have such a surge of requests for myocarditis. So I would say probably it's not so frequent.
Yeah. So what would be reasonable to expect? Myocardial injury, of course, can be non-specific. The troponin rise is observed in about 25 to 30% of COVIDs. And in many cases, I could imagine it is simply the right ventricle that has to work against this lung that is severely diseased. So there's a strain to the right ventricular wall, and so some troponin is leaked. However, in myocarditis, one would expect a very dramatic increase of troponin, a stronger myocardial injury. That probably would help in differentiating one from the other. And then there is the coronary event, although I have not seen that many case reports or reports on really acute coronary syndrome related to COVID.
But if I may, this is an evolving matter, because if you search on PubMed, pulmonary embolism and COVID, you will find only few cases reported, but I can assure you that there are a huge number of patients. So we are probably starting to learn and to produce evidences on a completely new disease. So we can expect even increases.
Yeah, thank you for mentioning that. I know that so far, as you said, the numbers reported for pulmonary embolism were not very high, but some of the autopsy reports clearly say that there was a lot of intravascular thrombosis, and especially in the lungs. So this may be something that we still underestimate. And then myocarditis also is probably underestimated in some cases, because myocarditis can happen without a lot of dysfunction. So there can be just little dysfunction, but widespread inflammation. So that's why we still have to learn more about that. So that was
something. I don't want to talk too much, but it's something that I thought about. Our case, the case we published, presented with severe fatigue, which is a symptom that a lot of patients refer. So we might even concede that some of these patients actually have more or less the same, probably less virulent, but more or less the same scenario.
Yeah, that's a very good point, because fatigue is one of the symptoms that sometimes may be the most severe in myocarditis, because they just cannot adapt that well, and so their body just is tired. Yeah. So we discussed here in that paper, we already mentioned pulmonary artery catheterization is what they propose here, although I would think that a CT here would probably be helpful. And then they also talk about then the therapy that I also mentioned, the cardiovascular toxicity. So this paper is certainly interesting. In the interest of time, I would just wanted to mention the others. You can all download them. There's also a review here by Mohammad, Madjid, and others on the potential effects of coronaviruses in COVID. So it's also interesting. They basically comment on several things. It's almost a little bit more updated here, I had the feeling. So this is also an interesting read. And this one especially has this nice graphic where you have all the different potential mechanisms how a viral infection, such as coronavirus infection leading to COVID, may affect the heart, with risk for infarction, heart failure, and arrhythmia. We haven't talked a lot about arrhythmia. Arrhythmia is also associated with myocarditis. And it also has been speculated that some of the sudden deaths we see these days may actually be COVID. So I wanted to show, and then there's also a list of the current therapeutic approaches that are underway. So this is an interesting read here by Madjid and co-workers. And then the Chinese Society, this is how interesting these times are. I don't think that the Chinese Society would have published in circulation before, but now there is a paper from the society, how they deal with what their takeaway was. And actually, to sum up this paper, mainly they say two things that would apply to us here. in terms of the overarching principles, as they call it. So the priorities: number one, prevention and control of transmission has the highest priority, and I think we all have learned that, including self-protection of medical staff. And that's a point I want to stress. Everybody make sure that the medical staff is safe, because these are the people we need, and these are the people we need to protect to deal with diseases like COVID. And then the second one they bring is the patient, the conservative approaches to diseases that may be sometimes now more interesting. So I see from our cath lab, for example, patients who would have gone to the cath lab right away, all of a sudden they say, oh, no, you know what, we can do this on a conservative. I was always I'm still a more conservative cardiologist, so I sometimes think that's maybe a good thing. Sometimes, however, it's not good to wait. So, but in these times, the decision lines shift a little bit, and we have to make sure that we do not treat, if we can do that, if we can treat conservatively, that we don't ship these patients through hospitals. And so then another paper more general on the troponin. That's the discussion, Davide, you also had. What is the real meaning of troponin? So there's a very nice read published, I think, yesterday or today in Circulation on high sensitive troponin, what it may mean. And then what I also wanted to show is a proposal that I had put together, where a cardiac MR could be useful. And I think we should not use the cardiac MR as a screening tool for sure, but it may make sense in patients where we know it's myocardial injury clinically, and with the troponin, if it's really significantly increased, and then the cardiac MR may help differentiate between the different various sources or etiologies for injury that could be acute ischemic event or inflammatory event, so myocarditis. I don't know, so although I work with radiologists all the time, I am not a radiologist, so I was naive enough to say, hey, can we not just add some good T2 weighted imaging and to have a double rule out for lung and cardiac involvement? But of course, CT is a strong opponent, but competitor. But of course, it would be ideal to have just one scan and not have the patient go to 2 scans. So, Davide, I know I ask you all the time, it's so precious to have someone who has experience with that. So what is your thought on that, to add to a cardiac protocol, let's say coronal T2 weighted hastes, for example, to see are there inflammatory foci?
Well, we have normally in our routine protocol, even I mean before COVID, we have axial and coronal through fist acquisition throughout the chest, and we check. Of course, when you have subtle ground glass opacities on CT, this may go underseen on MR, but it's precious. As you said, you have it. You have to look also at the lungs.
Okay. So what do you if you would have to guess, what do you think is the sensitivity of the true fist then to identify inflammatory regions in the lungs?
I would put it in between a chest X-ray and a CT.
Okay.
I don't know if this is diplomatic enough.
Yeah. But it would make sense if you already have a scan. Then I don't
Absolutely
lose a lot. And the true FISP is probably also fast enough that you do not add long scan times. Yeah. Okay.
And you can do it also while the patient is breathing. You don't need.
Yes. Yeah. Okay. Thank you very much, everybody, for joining, and especially Davide for making the time. It was a pleasure having you, and thank you so much. And again, all the best for your work. Okay, and also my wishes go out to everybody else here. We will continue the specials, and we'll update and we'll present an updated list of papers in 2 weeks. So you will find these papers on the website for download, the PDFs, and otherwise, if there is something you want to specifically put forward to be discussed here, feel free to send me an email. Bye-bye, everybody.